Hey everyone, welcome back. I hope you had a minute or two to stretch. My brain is so full after this whole afternoon so far, and I'm really excited to get to host this last and facilitate this last panel on food as medicine. I hope that everyone else is as excited as we all were backstage as we were talking through this. We're just the amount of insights and discussion is really inspiring to me, and I think everyone else. So for our next panel, we have a powerhouse panel, and it's going to be three physicians who focus on upstream prevention and specifically food security programs for their areas. I'm going to go ahead and show you a case study similar to the last panel we did. We're going to go through a case study, and that'll just help us frame this discussion and think about how we might actually talk through some of these interventions. So I am going to call up. I guess I'll just do this. And I will put this in. I'm sorry, I'm struggling with online PowerPoint. You're going to have, there we go. It's not quite in presentation mode, but I think it'll have to be good enough. So the case study is as follows, and I'm hoping everyone can see this. Here we go. So a state Medicaid agency is exploring implementation of a food as medicine pilot study. FIM is the acronym for food as medicine, specifically medically tailored meals and medically tailored groceries. And this should improve outcomes and reduce treatment-related complications among members undergoing active cancer treatment. Interest in this approach is supported by national oncology organizations and recent research highlighting the key role nutrition plays in cancer recovery and toxicity reduction. The agency has identified three trends driving interest in an FIM intervention. First of all, rising cancer treatment costs are driven by high-cost therapies, treatment toxicity, as we said, and avoidable ED and inpatient utilization related to malnutrition and complications. Second, high prevalence of food insecurity among Medicaid adults, which is linked in multiple studies to worse cancer outcomes, increased symptom burden, lower treatment adherence, and higher utilization. Finally, gaps in nutrition support in the current benefit design. Nutrition counseling is covered, but medically appropriate food access is not covered. So the agency seeks to test whether structured medically tailored meals or medically tailored groceries could support members during chemotherapy, radiation, and recovery, and whether oncology practices could help identify eligible patients. The pilot will test and potentially validate a benefit approach that could be implemented statewide. So with that, we're going to introduce the panel. And I'm going to ask them to start joining now. And while they join, I will introduce them in a second. But while they join, I want to just encourage everybody to submit your questions as you have them, and we'll get to them at the end of the session through the Q&A function in Zoom. So I see that the panel is here. So I'm going to drop these slides now and get back to looking at everybody in Brady Bunch form. So thanks everybody for joining. I'm just going to introduce you quickly. One of the things that I thought was great about the last panel was that as everyone started answering questions, they provided a little bit of the context about where they come from. I can tell everyone who you are and what your title is, but I can't give much more depth than that. I think you all can do that much better than me. So I'm hoping you'll give a little bit of context as you start to answer the questions of what you do, where you work, and how it affects what we're talking about today. So first of all, Dr. Laura Makaroff, she's the Senior Vice President of Prevention and Early Detection at the American Cancer Society. Dr. Julian Stia is Medicaid and Benefits Integration Director at Share Our Strength. And finally, Dr. Kofi Essel is the Food as Medicine Program Director at Elevance Health. So thanks all three of you. This is great. I'm so excited to have this conversation. And so I'm going to follow the framework that we talked about earlier today with Becky and Ugo and kind of follow that framework, our new framework that we have in the issue brief. For those of you who weren't with us earlier today, the Academy has published a framework issue brief, and you can find that on the Academy website. And we will be going through these questions kind of in the order of those domains of the framework. So first of all, I'm going to start with you, Laura, and how we frame this framing in the framework. Can you talk a little bit about how food insecurity intersects with cancer outcomes? Kind of what are the most meaningful outcomes that an FIM program can influence? and not just, well, during active treatment, but also maybe longer term.
Yeah, sure. Happy to. Thanks, Sarah, and great to be with you all today. It's a really great question. It's something I think about a great deal in my role here at the American Cancer Society. And, really the evidence base has grown pretty meaningfully in the past few years. I thought I'd just start with the scope of the problem. We know a couple things. One, cancer is becoming more common, and we know that 1 in 3 people will have cancer in their lifetime. So that means like a lot of the population is infected by cancer either directly or indirectly through caregiver support. We also are seeing really concerning trends in earlier age onset for many cancers. And so then we couple that with what we know about food insecurity, estimated, I think the latest data from maybe 2022 says in all households, around 12.8% of households are food insecure. But the statistics are really much higher for patients with cancer. And the literature says, 17% to 55% of households with people with cancer are food insecure. And this gap is driven by many things, including the cost of care, inability to work, financial burdens of cancer treatment. In my own work at ACS, one of our projects is our big Hope Lodge program. So we have Hope Lodges around the country where people stay with us for free when they're seeking cancer treatment far from home. That's all comers. We don't have any financial means testing for people to stay with us. We did a small pilot looking at available food insecurity in our patients at Hope Lodges. We found that 42% of all of our guests, again, all comers, all different parts of the population, answered the food insecurity screening questions as positive. So 42% of our population that we see in our Hope Lodges are food insecure. And then I think importantly, I'll get to like where active treatment and survivorship, but let's just talk a minute about how food insecurity and cancer, they don't just simply coexist, they're really interconnected. Cancer diagnosis impacts life in many different ways and can impact diet through both the treatments that alter appetite and taste, the symptoms of cancer or side effects of treatment that really impact one's ability to source or prepare food. And then the financial toxicity of cancer is well known. We know that there's many, many parts to that. So this really vicious cycle of cancer causing financial hardship contributing to food insecurity, worsening cancer outcomes. So what does this mean? Like, how does food as medicine matter in both active treatment as well as longer term survivorship? Let me just speak a little bit to that, not getting too in depth because we can get more in depth as we go in the panel, but let me set the stage a little bit on those topics. So, importantly, and for this audience and all of you, the proximate outcomes we care about in active treatment is treatment adherence and completing treatment. Both new and persistent food insecurity are negatively associated with treatment adherence. And it's really not trivial. I did do some, reminding myself of the literature. And what I found is, patients who are persistently food insecure with cancer had a 13% increase in non-adherence to treatment compared to food secure patients. So that's really not trivial. And if we go look at medication level, one study, found that 55% of patients with food insecurity did not take a prescribed medicine because of cost. That was compared to just 13% of food secure patients. So that's also not trivial. We also know that during active treatment, food as medicine interventions like medically tailored meals and medically tailored groceries do have an impact on both treatment adherence, completion, and quality of life. And there are some, early emerging randomized controlled trials demonstrating that. So I think that's really promising. And then if we move into survivorship, we have other things to think about. So in survivorship, the population of cancer survivors continues to grow. I think it's a super important point to remember that, currently there are about 18.6 million Americans who are cancer survivors. That represents about 1 in 18 people in the US. And we're projecting the number of cancer survivors will increase to over 22 million by 2032, excuse me. So that means like this longer term picture of how we think about cancer survivors in the context of our populations becomes more and more important. And food as medicine programs really have this opportunity to influence both reducing the risk of recurrence as well as other chronic diseases as kind of following treatment completion. So I think importantly, as I kind of like wrap up my opening comments here, the bottom line really is that food insecurity isn't really just a background social factor in cancer. It's really a clinically active variable that we have opportunity to make a difference in. The programs that we have for food as medicine in active treatment make a difference in treatment adherence, completion, quality of life. Reducing caregiver burden, I think, is an important part to include as we think about cancer and cancer treatment. And then longer term survivorship matters as we think about nutrition, food security, and reducing risk of recurrence, as well as reducing the impacts of late and long-term effects of treatment.
Yeah, some of those stats are staggering. I
Yeah.
didn't even realize that. Wow. I don't know, Kofi or Julian, if you have anything to add to that. based on where you come from?
I just want to, I mean, those are staggering stats. The food insecurity rates that we're seeing, how it affects trade-offs between medications. I'm writing some of these facts down, Laura, because really, really staggering. I think other people need to know about it. I think these facts, they drive action. At the end of the day, it drives action.
I would just one more comment and maybe extending Laura's comments about cancer. I know we're focused on this cancer case study, but um, do any of you have additional comments about how one might extend some of these thoughts into other disease states or conditions or populations? And I think the whole point of this is to start to dig deeper and think about the whole person that we're talking about. And when you start to think about things like I hadn't really thought too much about how medication and treatment adherence is associated so closely with food insecurity. So I guess, do you have other pattern? The rest of the panel, do you guys have other patterns that you see that are similar to that you might not expect that can help us go deeper into that whole person?
I can throw a few things out. Julian, feel free to jump on as well. Sometimes when I talk about food insecurity, I talk about sort of this pattern that occurs in households. Typically, when a household experiences food insecurity, it typically is a result of some sort of financial hardship or some other hardship. It comes out of somewhere. Food insecurity is not intermittent fasting, right? It is not a thing you're doing on purpose. It is an involuntary experience that an individual faces, and it creates this sort of cascade of events. So if a family has a sudden financial hardship for a variety of reasons, such as having treatments, transportation challenges, spending money on drugs, a lot of other things that are going on in one's household, not able to work, right? The things that Laura is mentioning. If families having financial hardship, it's going to set off this cascade of events. The first thing families typically describe is their food budget changing first, because
Mm,
that food budget is so flexible. So they oftentimes will focus on that food budget and change and adjust that initially. And we call that oftentimes food anxiety, a constant
mm,
perseveration or preoccupation with where your next meal is going to come from. After that drop in sort of that anxiety starts to increase, we then see a drop in the quality of food people are getting. People will then gravitate towards foods that are what we consider more ultra processed, higher in caloric density, lower in nutritional value. You tend to gravitate towards these foods because they're cheaper, easier to access, they're cost effective, they're incredibly tasty, they're designed to be that way, right? And so people will gravitate towards those foods. On top of that, you'll see sometimes people having a struggle with their cognitive bandwidth because of the ability, this increased stress, this palpable stress is there. They'll have difficulty in focusing in the future, right? So a lot of things end up being short term. They're not able to have this sort of long-term view and plan. Their prefrontal cortex is affected in their ability to do different things. So you'll see that also as a result of this as well. People will have different trade-offs. Laura talked about drugs or medications. You also see the idea of utilities. So we sometimes say, do you want heat or do you want to eat? Right? So you'll see that affecting utilities in the home as well. And some people say the rent eats first, right? So at the end of the day, I have to pay my rent. I have to have a roof over my head. These things end up affecting my dollars to be able to pay for food. After the quality of food begins to drop, you then begin to see the quantity of food will begin to drop. Start to eat less food, right? So the idea of malnutrition can look a variety of different ways, but it also can be a decrease in the absolute amount of food. And then you see all the other results from that as well. If I'm not eating enough food and I'm going through these intense therapies, how is that going to affect my overall health? How is that going to push me into the ER, into being hospitalized, my recovery, and all those things that are tied to that as well. So I would tie utilities, I would tie the medications, I would tie hospitalizations, ED visits, quality of food. All these things are tied to food insecurity.
interesting. I'm going to move on to it's so interesting that I like rent eats first, and that's something I in other work in social determinants of health, it comes up a lot, like the trade-offs, like, oh yeah, sure, I can, I have food but I can't pay my electric bill. Like, well, then you're trading something, and that's not appropriate. But Julian, I want to turn it over to you in terms of kind of benefits. We hear a lot about there are folks on Medicaid especially may have access to SNAP or WIC benefits, which are the supplemental nutrition benefits, or other nutrition programs. But I guess I throw to you about policy considerations. So what policy considerations should be addressed up front to avoid any kind of duplicative services where the state might want to say, no, this is duplicative, therefore we won't cover it at all? Or like how could a pilot like this interact with existing benefits? Can you talk a bit about that?
Yeah, thank you. So this is something we think about a lot at Share Our Strength, which is a national child hunger nonprofit, and within the Medicaid Food Security Network that my organization, along with Health Begins, of which we heard from Dr. Manchanda about, like we and Health Begins work together on this network to increase Medicaid's investment and involvement in the food security and food as medicine space. Um, and I think a really important point to take away from thinking about food as medicine is that food as medicine programs, as we're currently defining in the more targeted sense of like medically tailored meals, groceries, and produce prescriptions, are actually complementary with the federal nutrition benefits rather than duplicative. Um, Even though some, it is very easy for policymakers and other stakeholders to feel like these are the same thing, but really these are things that work in concert. And it's kind of exactly what Kofi was talking about, which is like families every day are deciding what to eat. And when you have to stretch your dollars, something has to give. But if we're talking about a family who is maybe going through a cancer diagnosis and there needs to be medically tailored meals for the person who's getting active treatment, but if part of the care team is also able to help that patient's family access SNAP
Mm.
benefits at the same time, then that is a family who is more likely to be able to eat healthily, not only for the patient themselves, but also for the whole family. Um, because one of the biggest sources of tension in a household is when one family member is eating differently than the other family members. And you see this a lot with programs that give um, boxes of food ingredients instead, where it's like if you're asking one person to cook one thing for themselves and the other family members are going to eat a different thing, the more that you can increase the household food budget and have like unified nutrition education and nutrition and like healthy eating patterns, the more likely it is that that patient and their whole family is actually going to do the thing that you expect. Because this all ladders back up to the principle of like the best medication is the one that the patient actually takes. And in the food as medicine space, you cannot guarantee that people are going to do exactly what you expect unless you set them up with the conditions for success. And hence, getting people connected to SNAP and WIC alongside the targeted food programs is like creating those conditions of success where people don't have to make trade-offs between different programs. Um, and I think that shows in the evidence as well, where there's a 2017 JAMA study that shows SNAP is associated with $1,400 in per person annual healthcare savings per year. Um, so anytime that uh, a food and medicine intervention can get someone connected to public benefits, that means the whole family is going to do better. And I also want to connect this to HR1 or the One Big Beautiful Bill, which is that we are seeing right now that Medicaid and SNAP are getting cut very significantly. And one of the things that's happening in SNAP is for the first time, states will soon be responsible for paying a certain cost share for the benefit amounts that are going to people. And the amount that they're on the hook for is proportional to SNAP error rates. And SNAP error rates, and please forgive this slight tangent into SNAP mechanics, but this will all make sense in 45 seconds, which is that SNAP error rates are proportional to the quality of the applications that people put in to get onto SNAP and to renew their SNAP benefits. And one of the things that increases the quality and accuracy of an application is when a community health worker or a navigation assistant is helping someone fill out that application. And guess who is one of the stakeholders who can help people do a high quality SNAP application? That's food as medicine organizations in partnership with the provider team or the like MCO care navigation staff. So the more that we can have this integrated approach where we're getting people food directly, but then we're also helping them sign up for SNAP, stay enrolled in SNAP, and submit high quality applications, that is actually something that could then translate to a safeguarding of a state's budget because the more navigation assistance there is, the more that SNAP error rates can be lower, and therefore you can preserve the state budget to do whatever it is the state wants to do to maintain the core Medicaid and SNAP operations. Um, and the one other thing I'll just say kind of on this general topic of like, how do we make these things work in concert? I think it's also important, not only from the patient perspective, but like making sure that there's the voices and design around clinicians and community organizations. And that means getting on the same page about referral workflows, how screening happens, the use of closed loop referral tools, but in a way that is mindful of the different realities that different stakeholders have. And by building all of that together, then we can get patients connected to the maximum set of things, which then gets them connected to the maximum set of healthcare savings and healthcare outcome improvements as well. And one of the enabling policy things for that is to increase clarity on blending and braiding of funding, because these programs are paid for through this complicated mix of insurance, so Medicaid, commercial payers, and also USDA dollars and philanthropic dollars. So I think it's important that there's clarity on those things, because that is another thing that feeds into this like duplicativeness narrative, because different things are paid for by different entities. And I think that that does need to come from the federal government ultimately, but I think in the meantime, we can all be like talking about like what is like the patient-centered experience we want to see. And some of this is going to be paid for by USDA, some of this is going to be paid for by Medicaid, and some of this is going to be paid for in other ways. Um, but really, at the end of the day, we want to get people culturally relevant and nutritious food that brings back the joy and dignity of eating, because then they will actually want to do it. And when there's joy attached to it, that means it's not only like learning by doing when you receive food and eat good food, but it sets people up for success in the long run, because it is something that is a positive association rather than judgmental or penalizing.
It's really great, great information. And yeah, I have a lot of joy when I eat, but it's not the same for people who have a need. So I'm gonna pull on we'll come back to the financing, I think, in a little bit, but I want to just pull on the thread you just said about identifying patients and kind of turn it over to you, Kofi. You know, we talk as actuaries. I think a lot about attribution of members. So which members and how do you identify them? How do you decide what programs that they're really participating in and which program is affecting them? But specific to that kind of patient identification, and that aggregate number of patients is also very important when we're doing a calculation of the total cost of a program or the total savings of a program. So I'm just going to ask you, Kofi, like, related to your work, and just how do you think about physician practices, and in this case, specifically oncology practices? How should they be engaged in identifying eligible patients? And then kind of maybe what challenges do you think happen within those practices? And then are there other ways that you've seen to identify patients for a food program, especially a patient who's in an acute setting and very, like highly acute at the moment and maybe seeing their oncologist the most? Is that the best way, or are there other ways to identify those patients?
Okay, I like that. I like that. Okay, so there are a few things that I'm hearing in that question. One of the things that I feel like we are gathered here today to talk about is the business case around food as medicine. It's a question that many of us ask: is there a real business case around this concept of food as medicine? Is there something we should be leaning into, or should we be leaning out of it? And I think at the end of the day, Laura, you brought something to our attention, and I think just highlighting that I think is critically important in these conversations. I want to open up the aperture a bit as I dive into this conversation. When we think about food as medicine, typically one of the ways we can define this is that these are strategies or interventions that work alongside healthcare that give access to high quality foods and education, focused primarily on prevention, management, and treatment of disease, right? So under that umbrella, we can think about engaging individuals experiencing food insecurity and nutrition insecurity, but we also need to think about, just in general, individuals experiencing disease in general. They may or may not be experiencing food insecurity. Food insecurity is a large portion of this, but it's not only those experiencing food insecurity. And I want to highlight that, because at the end of the day, even when I start talking about screening in a few minutes, you may screen negative. but I might have other risk factors that would greatly benefit from a food as medicine intervention. There may be tiers in how I sort of interact or allow people to enter into this intervention, but at the end of the day, I think it's important to expand that conversation, recognizing that in a lot of the work we do, diet-related chronic conditions or whatever it may be, or even here when we're talking about cancer care, it's important to think about the conversation expanding beyond food insecurity as well. Now, if I am preparing and working with a clinic, an oncology practice in particular, and we want them to sort of identify the right patients for this kind of program, and we're thinking about the business case of food as medicine, part of me thinks, okay, how can we see the most return on investment? And so in those cases, sometimes I want to think about those who are the most sick. But then at the same time, if they are the most sick, they may not benefit from the intervention the most. Maybe it's somewhere in the middle that we should be focused on. That's a conversation we can have over the next few minutes. But I think at the end of the day, when I'm working with a practice, I want to first and foremost make sure they're aware of what Laura talked about. Right? I want them to be aware of the power of food as medicine in oncology, what food insecurity does, how prevalent it is, how invisible it is. How many of our colleagues, providers, staff members know that near 55% of patients are experiencing food insecurity who have cancer? Like that's unheard of. Why? Because food insecurity is often described as being invisible. So it's not always in front of you. You have to screen and know how to screen to identify it at times. So I think being aware and really informing that practice, making sure they're aware, bringing on people from Laura's organization for them to hear lived experiences, people who have had challenges with their food, had challenges with consuming foods, have challenges with accessing foods, and the resources that they were able to take advantage of to really help support them thrive in their health, whether survivorship, whether through medications, whether sort of dealing with some of the side effects of symptoms, toxicity. Like these are important things to bring in front of our colleagues, our providers, our staff, so they can see, hey, this is real. This is something we should be referring to. Why do I start there? Because if I don't see any value in referring, why would I refer? If I don't see any value in this program, this is just sort of a nice, check mark. But no, no, no. This is a meaningful program that can produce better outcomes for our patients and our families. And patients or families, guess what? They're also asking for this as well. So how do we meet them where they are? So I think I would start there. Number two, I would go into the importance of screening, right? So with screening, I think we talked about a little bit, Laura mentioned food insecurity screening, but food insecurity screening, you can throw in there nutrition insecurity screening if you're ready to do that. We can talk about dietary risk. We can talk about malnutrition, right? These kind of things are important to screen for in the clinical setting, right? Staff members having a platform where people can answer questions in a way that protects their identity, or more importantly, protects their dignity, as Julian mentioned. Why? Because if we're doing this in a way that calls people out in the middle of a waiting room, or it doesn't feel safe for that individual, I'm not going to share this with you because it is a very sensitive thing. And also, if I do share this with you, how do I know you're going to do anything about it? So if we're not ready to sort of respond to food insecurity or these challenges families are having, we shouldn't be asking these questions. So on top of that, so screening, identification of these challenges around malnutrition, food insecurity, dietary risk, and then referral into the right programs, making sure programs are in place, and then referring into these programs. Some of the challenges that you're highlighting and alluding to are, guess what? There's not a lot of RDs available, registered dietitians, oftentimes that see Medicaid patients, right? So they have a long waiting list. So that can be a challenge. Are there other nutrition specialists that can help? Sometimes there are, sometimes they're not. It requires a deeper level of understanding and skill, oftentimes, in the cancer care world. So it is something that's really important. We do shared medical visits and those kind of things as well, but those are limited. We also know there are limitations around the business of the practice. People have a lot going on. To add another thing on there, again, if they especially don't see the value of it, why would I do that, right? So there's challenges around the busyness of practices. There's challenges around having the right resources available. There are challenges I'll even throw in my group. So I work at Elevance Health, I should say. I should have said that earlier on. Elevance Health, previously known as Anthem, is a payer. What if I have a program going on for my patients, and then this other payer has another program going on, and this other payer has another program? The provider is like, which insurance was it? Like, it really just, it takes away the desire to want to refer, because I don't even know where I'm sending the patient. I don't remember what program this payer had versus this payer, or if this payer even had a program or not, or what the criteria are. So these become very complicated facts and make it harder for people to take advantage of these programs as well. But at the end of the day, I want to go back to the business case. We got to think about how we do that, and these are some of the ways in which we can think through that and make sure it's meaningful.
Thanks. That's great. And I'm going to launch off of another thing you just talked about a bit and turn it back over to Laura for a second. Dr. Machanda earlier today challenged us about the peril of ignoring equity in our evaluations and our measurements. So Laura, I guess I want to ask you, how do you see nutrition interventions, especially in cancer care, and how do they contribute to narrowing disparities in outcomes, and especially in particularly for Medicaid, but really for any population? Because I think one of the things I'm picking up that I hadn't thought much about is that for a case like cancer, yes, food insecurity is important, but that doesn't necessarily mean they shouldn't qualify for a food as medicine benefit because they've got a very specialized condition that is, nutrition affected. So anyway, I guess how do you see nutrition interventions contributing to disparities in outcomes, and then what risks arise if equity impacts are treated as secondary, as Dr. Machanda was talking about earlier today, rather than a core evaluation outcome?
Yeah, yeah. Super important issue and question. I may answer it sort of simply, and then I want to say a few things about what Kofi was speaking to, because I think there's some real pearls in there about supporting patients kind of as in the whole person approach and supporting care teams. I think there's like a long answer and a short answer to this important question about equity. And the short answer that maybe just gets to the foundational issue is that we can't leave equity as like a secondary outcome, because we will leave populations behind. We have to, it's a measurement problem. It's a challenge, but it doesn't mean a challenge that we shouldn't address together. We need to understand how food as medicine interventions, or any intervention, impacts different people in different settings with different lived experience, with different disease states and chronic conditions. Without that, without understanding the demographics, the other socioeconomic factors, all kinds of, geographies, access to care, all of those issues, we will leave populations behind and risk widening disparities versus narrowing disparities. I think in the case of food as medicine and food insecurity, nutrition insecurity, which is its own part of this, and cancer, there's a disparity just that exists there, like by itself, because of the gap and the differences we see based on compared to people with cancer versus the general population. There's just differences in what's happening with that population. So I think the short answer on the complicated question is that we have to maintain equity as a central part of our evaluation frameworks, of how we think about our programming, and importantly, to prove the point to policymakers and have the right data to demonstrate that these programs make a difference. I think a piece of this, I'm going to sort of pivot a little, because I think there's a few things Kofi was speaking to that are really, really important. And in the context of cancer also, and Julian said this too, about community health workers or other navigators or navigation support, and the really critical role that the navigators and navigation plays in cancer care. So cancer care is exceedingly complex for all kinds of reasons. One, the disease itself is complicated. The trajectory can ebb and flow based on where you are in your treatment journey, and who you're seeing, where you're getting care, what's possible based on your own individual cancer is very complicated. Navigators make a huge difference. We have mechanisms to pay for navigation now through CMS's principal illness navigation. And doing food insecurity referral and screening in a health system, utilizing your navigators or building a navigation team, however you can do that, is really important, because the navigators can help with all the things Kofi said, which is the reality is that, like, in a clinical practice, like, I cannot keep track of like which program is which. And we have to really fundamentally think about that, and having networks that are more easy to refer patients into and that are reliable, and that you're not picking up the phone and calling a place that doesn't have services available anymore, because that also can happen. Those things are part of building trust with patients, and we know that navigation can make a big difference. So we, in the context of kind of what I get to do at the American Cancer Society, in addition to the work we do for patients, we also do a lot of professional education and work to help health systems and cancer centers improve their systems of care at all kinds of problems in cancer, including food insecurity. So we've been doing some programming around food insecurity screening and referral with cancer programs themselves. And everything Kofi and Julian are saying is real. Like, that's everything that our partners, tell us and are learning about. So we have lots of resources available on cancer.org if the audience is interested in learning more about or looking at archive webinars where cancer centers and cancer programs are discussing like what are the issues they're facing and how and what are the successes and sort of best practices of these early programs to implement food insecurity screening and referral in cancer, utilize the care team, utilize the navigators, and get patients to the appropriate service, whether that's just food or whether it's medically tailored meals and the nutrition part of it, and then how that matters in the context of where a patient is in their cancer treatment journey.
Right. And Julie, I don't know if you have anything to add to the challenges and the various things that Kofi and Laura have been raising from your context with Share Our Strength or the MFSN.
I would just add that some of these things could be solved through better like data interoperability. Um, for example, like this issue of different payers for different things for different types of patients. Um, it would be really nice, and I don't know if anyone is doing this well yet, but I think they're working towards this in states like here in Pennsylvania, where I am. Like we're working towards a statewide closed loop referral network called PA Navigate. The more that we have systems like that that can receive the inputs of like this patient is covered by this plan and they fit these particular demographic or disease categories, and have a system that just automatically knows like, okay, well, these payers are reimbursing for these types of programs, then that reduces a lot of the guesswork on the part of the clinician or the navigator. To be able to, and obviously the other piece of it is, I mean, all payers should just try to do similar and good things, and state Medicaid agencies and um, CMS via the Medicare system should try to like raise all the standards as much as possible so that there's more uniformity in what's being offered. But just in the reality that we live in, where different payers do different things, I do think technology has a big role to make that easier for everyone involved.
Yeah, I know we were talking in the earlier panel about the low use of Z codes. I don't know if anyone has any comments about that, but is that something that could help to get to that? Or do you think that that's not really, for food security, is that not something that will ever really be widely used? I guess the answer is no. If that the way I'm skeptical, but also I think that it would be great if we could encourage providers to use those, and you could start to see that in claims data, which actuaries tend to use a lot. So we would like that.
Yeah, I think it's necessary but not sufficient is
Yeah,
probably my view on those, because not only are the diagnosis codes important, but it's also important to understand like what are the interventions that patients are receiving relating to food. So
good point.
making it readily available in health records and health insurance site data of like, is this person accessing SNAP? Is this person accessing Meals on Wheels? Are they already connected to a pantry? Um, we're really good at tracking that for medications. Uh, well, I wouldn't say really good, because all of us have experienced being asked a medication list a million times, and that's kind of frustrating. But can we move towards that in the food world as well, and the housing world and the transport world, so that we double check on this stuff every once in a while?
Yeah, that's great. I guess I want to move on to metrics since there are a lot of actuaries in the audience. And I guess from really Julian or Kofi or Laura, what you've seen, what evidence or metrics resonate the most with Medicaid policymakers when they're deciding to scale, and maybe even not just with Medicaid policymakers, but also with large payers like Elevance? What are the metrics that really resonate the most, do you think?
Well, I think I think there are a number of metrics that resonate. I think at the end of the day, when you're talking about endpoint measurements and metrics that really move the needle, people definitely want to see things around cost of care. People want to see, what's going on with ED visits and hospitalizations and medication usage, what's going on with primary care usage and specialty visits. Um, I think when we're talking about in this case, Laura highlighted some of the really important ones as well. We want people to do better. We want them to get healthier. What does that look like? Well, treatment adherence. It looks like completing treatment. It looks like being able to get to appointments, right? Like these are some of the things that really matter as well. But I would say those are will move. Those are sort of secondary or really important intermediary metrics that matter. Because if those don't land, we're not going to get to those other endpoints as well. So I would say all of those things are really critical to us when we think about these kind of interventions.
Great. Julian, do you have anything to add?
Yeah, I would agree with everything Kofi said just now, and would also add that I would be curious from this community slash encourage you all to think about like what are the 1 year things and then what are the 10 year horizon things, because I think it's easy to fall into the trap of thinking, oh, food is and diet is a thing that will just kind of hit us in 10 or 20 years based on heart attacks. But I think there is a lot of immediacy to it as well. And that's what Laura was talking about with like medication adherence. Medication adherence hits you within a days or months. I think there's also pregnancy outcomes is another great example where there is, if there was a chat, I would be dropping a lot of studies about how food as medicine and public benefits are linked to improved pregnancy outcomes, reduced infant mortality, reduced preterm birth. So we're talking about, NICU, we're talking about the stress and trauma of like infant death and maternal death. There's a lot of things that food can help with, and those are things where the outcomes will show up in 9 months or fewer, because that's how pregnancy works. And a lot of things in early childhood that are also really linked to healthcare and food. The other couple points I want to make about what I've seen resonate with Medicaid through my Medicaid Food Security Network hat and also previous hats I've worn in Medicaid partnerships, which is that I think like patient engagement and stickiness is also really important. Ability to align to quality measures and HEDIS scores as it comes through the NCQA system and like kind of making sure that we're ticking a lot of boxes. Like I think there's a lot of things where food is medicine and social care in general has a lot of alignment with those things, and there are opportunities to make sure that we're building alignment on those. And then one other thing that I just want to name an uncertainty, and it's something that maybe all the actuaries of the world can solve, which is um, I don't think we're doing a very good job of measuring family outcomes,
Mhm.
because everything in the medical system exists at this individual patient level, individual claims, individual health record. But like, what is happening to, if grandma has cancer, what is happening to the kid that grandma is taking care of? What is happening with a pregnant individual and their baby who may be covered by different payers, but they're in the same household, eating the same food, creating the same healthcare costs that come back to us as taxpayers and members of society. So I think the more that we can create data systems and models of care that account for that would be very interesting. And I look forward to the solution in 20 years.
Yeah. That's the family system issue is a huge one. I don't know, Laura and Kofi, if you have anything that you would add to that, especially Laura in the cancer context.
Certainly I would add like that would be very interesting and important. I think in the cancer context, it's really you think about a cancer diagnosis, really for at probably any age, but certainly if we think about let's just take like this trend of earlier onset cancer happening under 40. And so these are families impacted in whole new ways that we haven't, necessarily like seen in generations past. Cancer is like a major life event for any family, right? But if we think about like the under 40 people, these are, this is like the beginnings of careers, any job, like the disruption to jobs, the disruption to families, the disruption to child rearing years, and then the long-term implications of the financial toxicity of this. I mean, this is why food insecurity is a piece, right? And it really matters. But there are like much bigger issues to solve and understand like how to solve that matter when we think about cancer and the impact to a family. I think that's super compelling, Julian, and really, really important to remember is that none of this exists in isolation. And in the context of food and in a household, it is part of the household functioning. It's not, it's a little different than just like the patient takes a medication, like the family eats food and and then has joy and dignity in the experience of sharing food together.
Um, I'm going to go back to measurement a little bit just again because we have a measurement heavy audience. Um, but I think Kofi, I'll start with you from your perspective. Why is like real world clinical evidence sometimes discounted relative to more randomized evidence? And I guess how do you look at that? And how can our evaluation approaches better reflect those, those lived realities and again, making sure we're considering things like equity and other factors?
Yeah. I think I don't know. I understand why. I mean, I think medicine is a science, but it's also an art. And so, one of the things that we get a chance to do when we see patients, when we work alongside patients, is we get to understand and work with patients on a deeper level than sometimes a chart may show, and sometimes the claims adjustments may show, right? Like we get to understand the day to day, what's happening with food, what's happening with at home, what's happening with these other things that are occurring that makes it more likely for patients to be able to follow through on treatment or not. And sometimes that's not always reflected in the charts, but it affects how we then care for that patient. We take that information in and we apply it to our next patient and our next patient, and it affects the art of how we engage patients and families. These things are important. We shouldn't forget about them. You're not going to see the randomized control trial. It's not going to be in the randomized control trial, but they're important pieces that can influence the care and the outcomes for patients and families. I think I get why it needs to be rigorous, and I think in the hierarchy of healthcare and in medicine and in science, you have RCTs and the systematic reviews and all these things at the top, and the expert understanding tends to fall a little bit lower on that list. So that makes sense. But at the end of the day, I think it's important to figure out how we can integrate and triangulate these thoughts together, whether through expert opinion and expert sort of consensus on better strategies to move this work forward, whether through interviewing and bringing that into the conversation as well, because again, that helps this work and what's coming from the RCTs to actually become practical and real with patients and families. So, that those are a few things I would highlight.
Cool. Um, I want to circle back um, to talking about costs, and Julian, you definitely touched on this earlier. But bringing it back to our case study and this fact that we have a pilot that the state Medicaid department might want to expand. Can you talk a little bit about policy and financing strategies? And you and I have talked about this quite a bit, but policy and financing strategies that can help align incentives across the stakeholders and what might be impacting a decision in this particular pilot.
Sure, I can start, but definitely welcome Lauren Kofi's additional thoughts on this. First off, I'll say that we have a range of policy tools available to us to deploy food as medicine, but in the current policy environment, food as medicine and the provision of food is not by default something that is um, automatically allowed nor mandatory in our healthcare system and the way that it pays for services, and the way that we will most definitely pay for antibiotics for an ear infection. Like we are not there yet, but there are a lot of flexibilities that do exist, and that includes like Medicaid in lieu of services, Medicaid 1115 waivers. Um, there's value-added services, and there's the ability to put food services and food-related like wraparound navigation services into value-based care arrangements where there is some flexibility on what clinical systems are doing. So I think all of these flexibilities exist, and they've continued to be developed at the state level. Like somewhere in the neighborhood of like 11 or 12 states are doing some form of in lieu of services to pay for food. Um, and I think this is a really positive development in testing these models. I think some of the things we need to be intentional about include the fact that the food system has historically not participated in the medical system, so they are not used to
Mm.
payment after rendering a service. They are not used to um, individual level private data transfer to the healthcare system. And some of these things mean there need to be upfront investments in the ability for local food organizations to participate in these systems. And I think the other thing that's important in the design of these policies is that there needs to be like not only all the good programmatic design that Kofi was alluding to around like clinical practice, but I think there's also important considerations around creating incentives for CBOs to participate, and making it easy for them to participate, creating incentives for health plans to um, actually want to provide the program, because I think there can sometimes be a tension between the availability of a program and the concern about like, oh, what if every single member under the sun started using this program and it bankrupts us? And I think sometimes we fall into the trap of thinking, oh, everyone's going to use this and it's going to be really, really hard. And on the other end of that spectrum, sometimes we have programs right now that are reaching very, very few people because the outreach efforts are not that strong, and the outreach efforts may not be equitable in terms of making sure we reach different people in different communities, including in rural areas, including among non-English speaking communities. So I think both of those forces are at play, and we really need to think about like what are we trying to achieve, and can we hit the Goldilocks on that? Um, and I would say that um, what can help us reach policy alignment probably would be if there is, payment for outcomes rather than payment for volume, or payment for like just having the existence of a program without actually tracking how many people are using the program.
Hmm. Any other comments, Laura or Kofi? If not, I'm going to invite, actually, while you're thinking, I'm going to invite Annette to join us and facilitate any audience questions that may have come in. But Laura or Kofi, do you have any additional comments on sort of state and costing out from the states?
I don't have anything.
Okay, great. Hi, Annette.
Hi. So, actually, some of the questions were already answered. Julian just answered the question that came through from the audience um, about food not being a covered benefit, but how important it is, and talk about the kinds of things that we can do to allow food to be more participatory in the healthcare system. So Julian already answered that. I first of all, I want to thank the panel for opening up my brain to the connection between food insecurity and cancer. I honestly had not made that connection. And Laura, your statistics at the beginning kind of blew my mind. So thank you for that. Um, so I think I do have a question, and since I called on you, Laura, I'm gonna pick on you. So what types of results or what kinds of stories can we tell or narratives to help bridge the gap between like pilot data and organizational data and then ultimately policy action? What do you think is the pathway that would facilitate moving from, you know, results from a pilot program to actual policy?
Mhm. That's a great question, Annette. And I guess if I had the answer, we maybe would have a better solution for everybody. But here's a few thoughts. And I suspect there's lots of other thoughts out there, but a few thoughts. In the work that I get to do at ACS and what we do on the policy side, also in the Cancer Action Network, you know, the I think policymakers are used to hearing about heart disease, cardiovascular disease, diabetes, right? And I think cancer becomes like this thing that's like, oh, it's too maybe it's like too complex, or it's too scary, or it's too whatever, or maybe it's been interpreted as like it's doesn't affect that many people. So I think starting with sort of where I started, which is that cancer is becoming more common, and like the population level prevalence of cancer for like, 1 in 3 people will face cancer in their lifetime. And then you take the families connected to those 1 in 3 people, that impacts almost maybe all of us. So I think starting there to recognize this isn't just a side problem, that cancer is like an everybody problem. And then second to that, the statistics, which we could, you could look them. Cancer Action Network, ACS Cancer Action Network has some of those things written down for policymakers. I think making the case that addressing food and nutrition security for people with cancer matters both in the immediate of treatment adherence, which does drive down costs also, right? If someone is not taking their medication because they're choosing between the medication to reduce their nausea and food, which is very simple. I mean, there's lots of other parts, but a very simple clinical example. And then that patient ends up in the ER because they're vomiting uncontrollably and they just needed their anti-nausea medicine at home. Like those are real like examples that happen to people when they are facing cancer plus and have food insecurity in any level. So those kinds of things in the acute treatment, and then addressing the survivorship issues that, especially in this younger population part that I'm bringing up around the earlier age onset of cancer, the risk of recurrence and long-term survivorship will continue to increase, right? We have more younger survivors, we will have more risk of recurrence. Those are very costly conditions. And so, I mean, me as I'm a family medicine physician, so I'm thinking, of course, all about the family and the person. But when I think about policymakers and what's going to resonate, what you all can help us with as actuarials is like, how does that translate into costs and how do we build this health system that is cost effective, also patient centered and cares for the whole person and family.
It's great. Sarah, do we have time for any more questions, or do we have to wrap it up?
I think we need to wrap it up because I'm going to invite Becky up for closing the day. Hopefully she's still backstage waiting. And there she comes. And first of all, I just want to say thank you to the three of you. This is an amazing panel, and I'm really honored that I got to talk to you all about this stuff. I hope you liked it as well. I think I want to circle back to Dr. Manchanda's talk from earlier today and just say, for the audience, he's challenged us to really think about how we look at value and to broaden our focus, and also think about how we can get more involved with additional stakeholders, with additional metrics, with additional ways to look at the world. And I think the other theme that I've heard a lot today is the whole person, and how do we think about that whole person, these human beings that are behind every number that we look at. So I guess I would just encourage the audience to be thinking about that as you go about your actuarial work or other work, and consider all of these factors in the framework that we've developed that's in the paper. And Becky, I don't know if you have any closing thoughts, but I wanted to make sure you had a chance.
I want to thank everyone for their participation today, whether as a panelist or an audience member. We don't see this as, the end of the project. We really see this as a checkpoint in the project, and we hope that you'll continue to share your feedback, your thoughts on what you heard today. I think actuaries are challenged with developing models for really complex situations, right? And incorporating this whole person perspective reflects that we have a very complex healthcare system, and, building a model to reflect that is not an easy challenge. So I encourage you to share your feedback, whether you're an actuary or a non-actuary. It will help us to build that context and build better models and ask better questions. So thank you so much for being here today. We can't do this without you.